The recording will be posted on the committee's webpage after the meeting. For everyone's reference, today's agenda can be found under the first tab in the meeting materials. As a reminder for everyone, please remember to use the primary care committee email box to send updates or questions. And if you are not a member of the committee, please turn your camera off. Now I will turn it over to Chair Dr. Judy Zerzenthal to call the meeting to order.
Excellent. I was going to say good morning, but I guess it's good afternoon, everybody. Thank you for joining us on Zoom. As you can tell, I have a cold and I'm sort of losing my voice, so we'll see if I can keep it going. But it is 2:01, and I call the February 29th meeting of the Advisory Committee on Primary Care to order. Thanks, everybody, for joining us. I'm going to start with an overview of the agenda. Can we get the slides, please? Or I'll just talk about the agenda. We'll start with roll call, and then we'll vote to approve the meeting summary of the January meeting. We'll have public comment. We'll start to discuss the workforce development memo. We'll have a presentation from the Department of Health on another policy recommendation that we're going to explore next about patient engagement. After that presentation, I'm not sure if it's Shane or Gretchen from the Center for Evidence-Based Policy, and I will both present on multi-payer alignment. So those are two more topics. Then we will wrap up and adjourn. So, and there is that. So thank you. So I'll start with roll call. I'll call on members by first name in the order listed on the agenda, which is alphabetical by last name. When I call on you, please unmute your microphone and let us know you're here, and then go on mute again. So, Crystal? Sharon Brown? Tony?
I'm here. Good to see everyone.
Excellent, thanks. Michelle?
Hi, I'm here.
Great. Tracy?
Here.
Thank you. David?
Hi, I'm here.
Perfect. DC? Sharon Eloranta? Greg?
Hi, I'm here.
Oh, great. Thanks, Greg. Chandra?
I am here.
Hello. Meg? Cheryl?
Hi, I'm here.
Thanks. Lon?
Good afternoon. I'm here.
Hello. Katina? Mandy?
I'm here.
Hello. Jonathan?
Hi.
Hello. Sarah? Linda? Sean?
Here, thank you.
Thanks. Stacy?
I am here.
Hello. Ginny?
Hi, Judy. I'm here.
Great. And Maddie?
I am here also. Good afternoon.
Excellent. So now I'm going to turn it over to Rochelle, who will facilitate review of the January meeting summary.
Thank you, Judy. Please join me in turning to the meeting summary in the meeting materials. The recording of the last meeting is posted on our webpage. Is there any discussion of the meeting summary or proposed changes? And if not, would someone like to make a motion to accept the summary? Any discussion of proposal? All in favor say aye.
Hi.
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 Aye.
Any opposed? Okay, it looks like the January 23rd meeting summary is approved. Next, we will open the floor for public comments. Okay, the public comments begin at 2:10. So we'll pause for a moment to see if there's any member of the public that wishes to provide public comment. Please raise your hand when you are called upon. Please state your name and affiliation, if any, before speaking. Please do not raise your hand more than once. This helps to ensure that everyone has a chance to speak. You are also welcome to provide comments in writing via email at any time. It doesn't look like there's anyone that has public comments, but we can't close it until 2:10, so. Just wait to see. Well, is it will
me-
provide public comments?
So I start to talk about tab 4.
You could in the meantime, and we'll monitor for raising hands, and then we can close it after you talk about tab
Okay.
4.
That sounds great. So we have a small change to today's agenda. We're not going to vote today on the memo, the draft workforce memo that is under tab 4. Some of you may have noticed that yesterday Milbank released their U.S. Primary Care 2024 scorecard report. And we'd like to incorporate some of those findings into that memo and also give you a little bit more time to look at it. So we are going to do that. Under tab 4, you'll find the draft workforce development memo. Please look at that, and if you have comments or things that you'd like to provide feedback on, please give those to us by March 14th. And we'll incorporate that and then update the memo with the Milbank scorecard, and we will vote to adopt on the next meeting. So, so no voting this time.
Please just go ahead and email your comments into the primary care email box.
I guess the other question is our Department of Health friends here? Oh, Pat's here. Oh, yes.
All
Yes.
three of us are here.
Oh, perfect.
Just one
There's a
more
lot
minute
of
for public comment.
names to scroll through.
For the record, I still don't see any hands raised.
Okay, it doesn't look like there's any questions or any public comments, and it is now 2:10, Judy, so we can move on to the next item on the agenda.
Okay, perfect. I think this will hopefully be some good discussion, and I'm excited about the next presentation. We will welcome 3 members from the Washington State Department of Health that are going to help us take a closer look at our next topic that we're diving into, which is patient engagement strategies that are underway here in Washington. So joining us today, we have Kyle Unland, who's the Community-Based Prevention Section Manager, Dr. Charles Kaima, who's the Chief of Healthcare Innovation, and Pat Justice, who's the Executive Director of Rural Health. and they are all going to present on aligning primary care and public health to advance prevention and whole person care in Washington. So thank you all very much and take it away.
Thank you, Judy. Really glad to be here this afternoon. Can you hear me okay?
Yes.
Okay. So do I advance, should I share my screen or will you be advancing the slides from that end?
We're happy to advance the slides for you.
Okay,
You're sharing your slides now.
sounds good. Yeah, so we can move to the next slide. Yeah, thanks. We're really glad to be here with my colleagues. And today we really appreciate you for giving the State Health Agency the opportunity to share some public health perspectives on really the topic of investing and improving primary care, which we think is critical to improving health in our state. Many of you are aware of what the state agency does and really want to emphasize our values, which is equity. Really recognizing us as a state health agency, our North Star is really looking at how we can optimize health for every Washington resident, irrespective of where they might live or their demographic background, as well as we really emphasize taking an innovation approach to the things that we do. So we always constantly looking for ways to improve, and both in terms of the work we do, as well as being a catalyst for innovation in the health ecosystem in the state. And public health is not a business that any single entity can do alone. So our role is really to build partnerships, and so engagement is a priority for us in terms of working with partners and doing the work that we do. We can go to the next slide. So, but first, to kind of set the background for the discussion, which your focus is on, of this subcommittee of the board is on primary care, which we think is a critical topic. Because it is where we have the opportunity to address the topic of prevention in the health system. And while this matters is that prevention is costly, right? If we don't invest in prevention, then we're paying for it in other ways. We know that healthcare costs are rising in an unsustainable manner, which is part of the concerns about, for the state, but for the nation as a whole. It's consuming way more than a high percentage of our economic output. And even interesting when you look at the details of those numbers is that more than a quarter, so more than 1 in 4 of those healthcare dollars, we're spending it on diseases that are preventable. So these are things that if we are putting the resources into prevention, both in terms of public health as well as primary care services, we could reap a huge return on investment. So it is really a big opportunity for us to recognize that we can prioritize prevention in healthcare delivery. And we'll talk a little bit more about the risk factors on the next slide. So these are some of the leading, so when we say diseases are preventable, so these are some of the common risk factors that are driving a lot of the health conditions, whether you're looking at heart disease and cancer, which those two alone account for more than 50% of deaths that we see both in the state and in the nation, right? So if you look at the underlying risk factors that drive deaths and the disability in the states and in the country as well, we see that these are things that we have the resources to do something about them, whether it's tobacco use or excessive body weight or looking at high blood glucose. So these are things that are really actionable. It's not things that we're helpless about, and things that if we can invest better in a primary care oriented system that is connected with public health services, we have the tools and the resources to do something about this. And as we've seen, these are really contributing directly to our increasing healthcare costs. I can go to the next slide. And something that is important to emphasize, so we just wanted to share a few examples of the gaps we have today when we talk about clinical prevention, and to really highlight again some of the disparities that exist. So one of the things that we'd like you see as a team in many of the conversations today is the disparities that exist, whether it's in terms of rural versus urban divide, but as well as between different racial and ethnic demographic groups and the economic subgroups of our population. One of the things we see is that there's been previous research that showed that in our state, there's significant disparities when you look at the uninsured, those with lower income and those living in rural areas when it comes to uptake of clinical preventive services. So as we think about investing in primary care, we need to also think about how to close some of those gaps that exist. We know that the COVID pandemic has made things worse when it comes to clinical prevention. It made sense at the early phase of the pandemic to delay the non-emergent care, but some of those delays are continuing to linger today, where it's been challenging to re-engage a lot of our population back in the care delivery system. So we need to again bring back the emphasis and attention back to routine and primary care. And we know again that a lot of the risk factors go undiagnosed. So people, a lot of our population are living with high blood pressure, with undiagnosed diabetes, and even more so undiagnosed pre-diabetes. And these are things that we have the tools to make modifications. And if we don't, then that continues to lead us down a path where we spend more on tertiary care. We can go to the next slide. So knowing that chronic conditions, chronic diseases as a whole are really the big drivers of both healthcare expenditures as well as poor outcomes that we experience in our system, we wanted to share our public health lens to how we approach disease prevention. And if you look at this framework, you see that it's not just a public health business. We see the public health and the healthcare system working together. This is the same framework we use at the state level as well as the national level at the CDC. And it has kind of four components of approaches we use in disease prevention. One is, it starts with the data. We need to have good, what we call in public health surveillance, right? Which is really a technical term for our data and information systems that tell us who has what disease and what risk factors and where are things trending and what are the differences between population subgroups and what opportunities do we have? How do we know when we're making progress? So there's really investing in our data systems and in the technical skills to be able to do this kind of analysis. And then once we have those insights to really understand the risk factors and the distribution in the population, we then go into the different interventions that help to address that. So one, starting with understanding the environment shapes behavior and shapes outcomes. So there are environmental approaches like policy around smoking cessation, laws where you can smoke and where you can't smoke, as well as things that shape the built environment. Seeing that our people have access to infrastructure to be physically active and to have access to healthy food in the environment. So all those fall into what we consider environmental approaches. And then more relevant to today's conversation is the last two parts of the framework, which is the health system interventions, right? Which is really where primary care is very critical. As we'll talk about in the next slide, but the healthcare is really that opportunity for you to engage individuals as well as families and communities in really having that one-on-one personalized conversation about what what it means to be healthy, about the resources that they need, and then recognizing that we cannot meet all of those needs in the healthcare system, and being able to connect individuals to high quality community-based programs and services that can complement what we can do for them in the healthcare system. It's kind of the two critical elements that helps us to deliver high quality preventive care. So next slide. So on this slide, we wanted to emphasize how critical primary care is in that process, right? Because so when we talk about primary prevention, we're talking about the things that we do before onset of the disease, right? Before that disease takes place. And then secondary prevention is the things that we do then once we screened and identify the particular disease. So we see that this person has hypertension or diabetes or cancer, whatever that might be. Secondary prevention are the things that we can do then to really try to prevent complications or to delay them, right? And then tertiary is more like restorative and rehabilitation when some of those complications have already occurred. And primary care really cuts across all the elements of the continuum of care for prevention. And when you have a weak primary care system that is fragmented, that is uncoordinated, and that has restrictions in terms of a lot of people don't have access or experience significant delays, then you see that our prevention continuum of care is really broken because we're not able to engage people and link them with critical public health services that might be their needs, such as infectious disease and STI prevention, or the tertiary care that they might need if they're already experiencing some complications. So really, we need both upstream and downstream interventions, and primary care is at the center of that model of prevention that we use in public health. Next slide. And these are things that the committee is more than familiar with based on all the conversations you've been having. So we're not going to spend a lot of energy on this slide, but we just wanted to share, for those who like to get more background on this, regards to some of the ways that the system is broken and some of the gaps that exist today. And part of it is really comes back to what you're discussing as a committee, which is we need to invest more in primary care and we need to incentivize primary care. Because that's part of the biggest challenge is that our system is not, unlike in some other countries where primary care is really recognized as the fulcrum of the healthcare system. It's not the case in ours, and we tend to invest more in procedures and in expensive, therapeutics than in prevention. So really recognizing that we need to address that in order to achieve improvement in outcomes that we seek. And also recognizing that workforce is a big limitation because we might have aspirations, but if you don't have the workers who are able to really provide the services, particularly in rural and urban underserved areas, we will continue to experience restraint in our ability to provide high quality primary care consistently. Next slide. And lastly, so we'll wrap up the introductory slides, and then some of my colleagues will share some of the programs we have at the Department of Health that align with patient engagement and community engagement, as well as provider engagement strategies. But we wanted to share our strategic plan, which some of you have, might be aware of. But in the last couple of years, the Department of Health worked on this transformational plan, which is kind of guiding some of the initiatives we're prioritizing as an agency. I just wanted to highlight that one of our 5 key priorities as an agency currently is this idea of health systems and workforce transformation. And for us, that means you can go to the next slide. So when we speak to the health systems transformation, next slide. When we speak of health systems transformation, what that means to us is fixing the challenges that exist in the US healthcare system. And the framework we're using to define that is from a study by the Commonwealth Forum in 2021 that really tried to identify why is it that every time, almost all of their rankings, which they do annually, the US health system always comes in as one of the least performing among the economically advanced countries. So they start to address the question as to why is that the case. So they're able to look at those countries that consistently rank highest in terms of health system performance and see what is different between those systems and US health systems. And they're able to identify 4 differences, which we use instead of as our North Star for shaping our approach to health systems conversations, is that this universal health coverage, figuring a way to do that, each country has its own way of achieving that, but it's a critical way and a critical element of, seeing that we're able to provide people access to the care that they need. And then the idea of building the system around primary care. So the systems that are best performing consistently are those that ensure equitable access to comprehensive primary care services. And they're able to address the administrative burden, because part of the challenges we have in our system is that significant resources that we have available is spent on administrative costs, which again, I know is one of the priorities of the board. And lastly is coverage for social services. We're really recognizing that social care is healthcare. There's no other way around it. It's critical that we're able to deliver whole person care so that individuals are able to be treated as the whole persons that they are to meet all of their needs in order for them to be able to focus on the more urgent issues we would like them to address as healthcare providers. So these are some of the challenges that are identified as to the things that are lacking in the US health system that are limiting us from achieving the optimum outcomes from the resources we invest in health. So this is our North Star when we talk about health systems transformation from a public health perspective. Next slide. And then lastly, again, we don't want to preach to the choir, but we're just really for level setting, the conversation is really recognizing that primary care is critical. It's in the primary care setting that we have the opportunity to engage individuals and their support systems and families to have a conversation about prevention and chronic disease management, and to develop those bi-directional relationships, working with patients to empower patients to do the things they need to do at home, as well as make use of the resources that is available to them to improve their health. And this idea of having a usual source of care. So it's been found consistently in the literature to matter when it comes to clinical preventive services. So when you look at things like vaccination or screenings, people who have a usual source of care are much more likely to receive clinical preventive services. And that is really a key role for primary care, that primary care providers play in the system, is that they give people that medical home where they know who to contact or who to reach out to when for any health-related conversation. and they're able to either provide a service or navigate them to the right setting to receive that service. And the last slide before Carl, it's just sharing some, so this is based on a work done by the Center for Health Innovation and Policy at UW, and kind of really summarizing some of the barriers that minority populations are facing in our state when it comes to accessing healthcare in general, and even more importantly, primary care. And again, you see that today's conversation, which is focused on patient and systems engagement, you see that some of those barriers, even when people are insured, there are still issues around intrapersonal factors around English proficiency, around health literacy, around cultural norms, and about trust in the healthcare system that could still prevent people from taking up care. Some of you are familiar with some of our numbers, right? We've seen some numbers that suggest as much as 1 in 5 of people who are covered by Apple Health don't even utilize the benefits, right? So those are some of the things that even when we've achieved healthcare coverage, we need that personal engagement and patient engagement to be able to really educate and address the barriers, other interpersonal barriers that people face when it comes to providing care. So Carl will walk us through some of our chronic disease as well as child health programs that address some of these topics.
Great, thanks, Charles. Go ahead and go to the next slide. And then one more. Very good. Well, yeah, there you go, right there. Okay, so my name is Kyle Unland, and I'm the Community-Based Prevention Section Manager at the Department of Health. So we're starting with this segment presentation, looking at childhood health programs. Childhood is a place where behaviors and habits are introduced and affirmed. Moving children and families down a healthier path is essential to preventing health issues in adulthood. So go ahead and go to the next slide. So our first program that we wanted to highlight in this presentation is the childhood vaccine program. So as I go through these slides, I'm not going to read everything on the slide, but just give some talking points to highlight some specifics about the program. Now, with the childhood vaccination program in the state, there's several barriers that really do restrict the success of the childhood vaccine program in the state. Those barriers include lack of capacity. So limited access to providers reduces vaccination services. Lack of access. Many practices will only serve established patients, and it may take months to get an appointment with to become established within a certain practice. There's pharmacy referral barriers. So many people are referred to pharmacies for vaccinations, but not all pharmacies vaccinate all age groups or serve children enrolled in Medicaid. There needs to be an increased capacity to serve children under the age of 19 and the ages at the pharmacy settings. There's also a lack of reimbursement within Medicaid and other health plan payers for providers and pharmacies, and barriers to increase provider enrollment. Vaccine confidence is now an issue, and it has been an issue for a while, but coming out of COVID, we know that there's some issues related to the confidence or the trust, vaccine trust that is out there. So we need to do a better job in the state really supporting vaccine confidence so that we can work with healthcare practitioners to provide information and resources that will support patients and families' questions. Go ahead and go to the next slide. The next program I wanted to highlight is the Early Childhood Comprehensive Systems Health Integration Prenatal to 5 Initiative. This program operates as an umbrella and focuses on bringing together early childhood systems, partners, and representing health, early care, and education, child welfare, human services to coordinate efforts to develop comprehensive supportive systems for thriving children and families. The program's intent is to increase family-centered care through the development of implementation and family-centered practices that honor racial, ethnic, cultural, social, economic diversity, and impact the family's experience and perceptions of care. Recognize the importance of community-based services and access essential services. through utilizing a strength-based approach. It also aims to promote universal developmental screening, including social emotional health engagement of healthcare providers in coordination, intake, and referral systems to support care coordination. Next slide. The school-based health services is a really big topic, but we're going to try to break this down a little bit and differentiate the services and the centers. So when we say school-based services, kind of an umbrella term for health services provided in schools. The centers or school-based health centers are a particular model within the health services, based services within schools. These centers partner with schools to provide integrated, comprehensive medical and behavioral health care to young people at school in a way that's accessible, youth-friendly, age-appropriate, and culturally responsive. Centers are effective at improving access to healthcare for young people and who may not or seek or be able to access care anywhere else, resulting in better health and education outcomes. Centers need financial support to be sustainable due to their non-traditional model. Longer appointment times, more time doing outreach, and then care coordination, etc., exist within this model, which again isn't that traditional for our current settings. And then we also deal with very smaller population sets. So the Health Services Center, the centers are a wonderful tool to be able to increase access and support for young children and families. Next slide. Strong Start Universal Developmental Screening Program is a statewide system to track developmental screening and referrals, no matter where they take place. The goal is to increase screening rates and connection to support at the age when intervention has the greatest impact. It's built to be interoperable with the EMRs, the electronic medical records, through an organization called One Healthport. Working with early care education providers and developers to add early care education providers as users. The goal is to close the loop between screenings done at the ECE, early care centers, and the primary care practice centers. So making sure that those two are connected and there's no gaps within the referral system. Okay, next slide. And the last slide in the child care programs is the Well Child visits. So the Well Child visit is a regularly primary care checkup to improve preventative care through early detection and support for behavioral health issues, immunizations, and early developmental screening. Providers often report they are unable to use tools for some of the screenings due to time and reimbursement issues and constraints. School-based health centers, which we just talked about, offer additional opportunities to perform well care visits and screenings for school-aged children, as well as other family members, depending on the individual clinic. Strengthening communication and coordination between schools and primary care is essential. More staff within healthcare to support the link between schools and healthcare offers the promise in improving support for youth and behavioral health challenges. Okay, next slide. And now we've got the opportunity to talk a little bit about chronic disease prevention and health promotion. Next slide. The first slide I want to talk about is the Heart Disease, Stroke, Diabetes Prevention Program. So this program is funded by the CDC, but it's important to note that due to limited funding, the program efforts have been restricted to only 4 of the 9 ACH regions, and that includes Better Health Together, Greater Health Now, Swatch, and Choice. The program uses a chronic care model as a framework to support disease reduction activities. Using hypertension as an example, the team works with the healthcare delivery system to encourage clinics to serving priority populations to form multidisciplinary teams that not only address hypertension, but also address social needs, including the social determinants of health and other health risk factors. They encourage the use of bidirectional referrals with community and other providers that can support the patient's treatment and prevention plan. Within the community setting, the team supports engagement of community health workers by providing training on blood pressure self-management, accessing resources, providing support to patients by addressing social determinant factors, and connecting social groups with the community. It also works with community organizations to address social determinants of health issues, reduce risk factors with hypertension, such as smoking, access to healthier foods, increasing physical activity opportunities, etc. We work to provide self-management and decision support by helping providers and patients with hypertensive and blood pressure information and resources that will help the long-term self-management practices succeed. Within information systems, we help clinics capture relevant data to identify factors related to achieving hypertensive reduction goals, quality assurance measures, and regional surveillance information about the priority populations who are most at risk for stroke and heart disease. Next slide, please. The next program I want to highlight is the Breast, Cervical, Colon Health Program. This program helps pay for breast, cervical, and some colon cancer screenings, along with access to treatment for low-income and uninsured or underinsured adults. 3/4 of the funding comes from CDC and 1/4 comes from state match. The program is only able to serve 15% of those eligible for the program due to funding limitations. Patient navigation assistance is limited to assist patients through the entire process of screening, diagnosis, treatment, and survivorship. The program has identified quality assurance processes to ensure evidence-based practices are followed, need to be strengthened within the healthcare system so patients receive optimal care. On a side note, the Breast, Cervical, Colon Health Program Medical Advisory Committee is in need of a family practice or pathology provider. If interested, contact Donna Oliver at doh.wa.gov. So just a little side note there. Next slide, please. The Washington State Comprehensive Cancer Control Program is a federally funded program and is an umbrella for other cancer programs within the state and ensures that the programs are coordinated and aligned to reduce risk, early detection, identification of better treatment options, and enhance survivorship in the exclusively funded, which is exclusively funded by CDC. Through this program, a collaborative approach was developed to support HPV vaccinations to reduce cervical cancer. In the first year of activity, there was 12,671 children immunized that were aged 9 through 10. At the end of the second year, 33,000 children were immunized. So this is a really big success in the approach to address HPV and cervical cancer. Currently, the state plan is being developed that addresses prevention, treatment, and survivorship, and systems to improve recommendations that will support cancer activities in all the state. So one of the things I just wanted to highlight before we move on to Pat to address the community-based outreach engagement services, many or most of all the programs that we highlighted were only funded through CDC, federal dollars. When those dollars go away or when programs don't continue funding, all those services discontinue within the state of Washington. That's why it's so important to think about how else to fund these programs or how else to support or collaborate with these programs. And primary care is just a really good option for this. Okay, Pat, on to you.
Thank you. So I'm Pat Justice. I lead the rural health team. It's Department of Health. And prior to this role, I was directing a patient-centered medical home collaborative. So nothing makes me happier than talking about how to strengthen and transform primary care. Can we go to the next slide, please? So I'm going to talk about a few things that were developed for COVID, but which have capacity to really serve people beyond that. And the first is the Caravan, which is basically a mobile health clinic. And of course, during COVID, it was doing vaccines and testing and really trying to reach out to underserved populations that wouldn't have otherwise had their needs met. But going forward, it's begun to do other things. So we've got glucose monitoring, blood pressure checks, naloxone distribution, routine childhood vaccines, continued work with COVID-19 vaccines, of course, and flu, and those are for adult and child populations. There are possibilities about how this could be expanded to extend and connect to primary care. And one of the intentions is, of course, to be able to respond to surges in respiratory viruses. But there are many possibilities about where this can go. But the COVID-19 funding was temporary, and so it needs a sustainable funding for long-term operations. Next slide, please. So the Department of Health actually has had a community health worker program now for quite some time. And in fact, I was blown out to learn that there are over 6,000 community health workers now in our state that have completed this training. We also have a leadership committee that is really working on policy and practices for community health workers. There are obvious connections to patient engagement, of course, for all kinds of populations that otherwise might be mistrustful of the health system. So this is something that where those folks are also saying we need to increase our funding because we need more capacity for training, and we also need more infrastructure to provide support and communication to these 6,000 community health workers. Next slide, please. So this is another of the COVID developed services, and Care Connect is a really amazing thing that happened where it actually started out with people who were quarantined, who had no way to, get resources, particularly those who are isolated. What it's developed into is a set of community care hubs. And then there are all these different community-based organizations and community-based care coordinators that assist people with all sorts of needs. Personal protective equipment for COVID, of course, but food assistance, medication deliveries, housing, childcare support, sort of all those things that can fall apart and that the pandemic really affected in a negative way. But going forward, this program can continue to really bridge primary care and social and health services for people to respond to community drive or social drivers of health. All right, next slide, please. And we'll go one more. So this is the third and final of the COVID-inspired programs I want to talk about. The Power of Providers, some of you may be familiar with. It was a communication program that went out to enrolled providers to help them with patient communication, dispelling the misinformation and bad ideas that were out there about COVID, and giving people some really well evidence-based ways to communicate, and then also promoting access to the latest clinical guidance, because as we all know, those were changing about weekly or so during the height of the pandemic. So we see that this is another program that has the potential moving forward to really connect up to providers and particularly primary care in a meaningful way, helping to give them tools to engage patients, getting out preventive services information, and really being a way that the latest clinical guidance can be distributed in a format that people can look at it without being overwhelmed. So this is another one where we want to continue beyond that temporary COVID funding. Next slide, please. So in my office of the State Office of Rural Health, there is also a grant that's less known, which is the Primary Care Office. And I'm really happy that we're beginning to build a new vision about how to expand from where we are. But at this point, we are providing a lot of workforce services. We facilitate a lot of federal programs, some of which you may have heard of, like National Health Service Corps, J-1 work visas. And we know there's a lot more to do about workforce, though, than we're currently able to do. And there's also this amazing opportunity to begin to partner more strongly with primary care on care transformation. And I've watched the work you've been doing, Dr. Zerzanthil, and really been so glad to see you take on this primary care transformation. And I think there's a tremendous opportunity for us to partner further. And the next slide, please. So within my department, we've also got a few things I want to highlight. So we've been doing population health microgrants. And when we started this like 6 years ago, our sense was, and particularly I must say this was more hospital than clinic, but they really were having troubles figuring out how to take care of sick people and do population health. Like, we can't provide this or that, so what do we do? So we want to give them a practice runway in rural health, and it's really expanded. So far, we've done 58 of these grants. They are from 5,000 to 10, usually 5 to 7, and people are required to meet with a group of community organizations, look at their local data, and prioritize a strategy, and then measure their success in improving it. Just kind of a simple idea. But if you haven't gone outside the walls of your clinic or hospital to work with community partners on a problem, this was an opportunity to give you just a little bit of funding to get that going. We had communities really leverage that funding. I always like to call out Jefferson Healthcare, which somehow did housing with our $5,000. Actually, they took our $5,000 and got a whole bunch of community partners to chip in on that. But these funds are really popular. The second thing I want to talk about is Grow Your Own, which is our evolving approach to workforce. There are many, particularly rural communities, that find great difficulty enticing people to come live there. And one of the barriers, frankly, is there's no housing. But we know that people who have ties to the community are more likely to be retained. It also provides an opportunity to recruit in a way that reflects the population of the community, so that the health workforce has similar characteristics as the population they're serving. And it's really about linking training programs, rural health programs, and ourselves as a facilitator to get all kinds of activities going: scholarships, apprenticeships, residencies. The health systems all over are starting to really experiment, and we developed a environmental scan of that, found some really exciting performing health systems, and we're now publicizing kind of some of the things they're doing. I'll quickly call out the Mason Health, which their local high school has a health services academy now. They offer scholarships to high school students, full ride, books, etc. And they then have a obligation to get to or they get to come back there and work. It's a service obligation in exchange for the funds. They are recruiting students that are the first to attend college in their family and who are bilingual as their priority. They started with nursing, and they're adding rad techs and lab techs. So it's a really exciting program. I encourage you to check into it. The last thing I'll mention, and then I'll turn it back to Dr. Chima for some recommendations, Learning Action Network. And many of you know about that approach. I sort of think of it as breakthrough collaborative light. But we have been working to integrate palliative care into rural healthcare systems around the state. We have 19 communities working with us right now. We've also used this Learning Action Network approach to rural EMS agencies and helping them sustain services. So we see that this approach could work for many priority clinical or service-related opportunities in primary care and other healthcare settings. And with that, Dr. Chima, I'll turn it back to you.
Thank you. And we can go to the next slide. Yeah, and so we wanted to just share a few ideas, as you continue to consider different ways to invest in primary care and to transform our primary care system. One of the points we wanted to share is really this idea of having a North Star around prevention and whole person care. From a public health perspective, we see that ultimately what will get us to the improved outcomes that we seek through the different reforms we're pursuing, right? So we think, there's a lot of investments and dollars in the system, but the more we can all be working in the same direction, whether we're in public health or in the state Medicaid program or social services perspective, is how can we all align around this idea of seeing that we can provide through the primary care system universal access to prevention and whole person care. And so how can we take some of those programs that Pat has just done a great job of really highlighting some of those initiatives we started with COVID funding, but I can really, we see them evolving as really wonderful opportunities for engaging the healthcare delivery system and linking people with community-based services. So the example is the POP program, which is really very effective at disseminating clinical evidence to providers in a relatable manner, as well as equipping providers to deal with challenges they may have with patient engagement and communication. The mobile-based, community-based services, which again provides that opportunity. If you think about the fact that we have people who are eligible, who have actually signed up for Medicaid, but are just not using their benefits, right? So the more we have the opportunity for community outreach to engage people in community-based services, as well as linking them back to primary care and connecting them to social services, the better we can see improvement in outcomes for the investments that we already have. And then the other point we would like to make is, as you pursue reform, is also look at payment reform that not only better incentivizes primary care, but also kind of looks at the definition of who we include in that definition of who is a primary care provider. Not necessarily change the definition of who is a primary care provider, but primary care workforce, right? So recognizing the primary care workforce, primary care as a team based business, and how can we expand that business model to include those critical care coordination, community-based services that are really essential for delivering whole person care and improving outcomes. So just thanks for the board to reflect on opportunities for expanding how we pay for care, such that we can actually have sustainable resources providing integrated community-based care that meets patients and individuals and families at where they are and provides them the resources and support they need. Next slide. And the second point we wanted to share about is around data. So we see kind of good quality data, which then provide with investments in analytics and research capability, we can begin to translate some of that data into insights and intelligence is critical to really driving transformation, because first is, as a system, we don't really have, like some other countries where there's like one national or state health service. What we have is a very decentralized system. So good quality data is then what gives us the opportunity for our data systems are interoperable and really have, using some of the new advances in technology and standards definition coming from the Fed as well, that allows us to really pull together what some people are beginning to call health data utility, which is kind of an improvement on the idea of information exchange. So it's not just about bidirectional exchange anymore, but really creating a data utility that then we can leverage to drive analytics that can then inform different strategies to understanding where we're experiencing gaps in the care delivery infrastructure in the state. An example is something that the Department of Health is trying to work with healthcare partners through the Healthcare Forum. We're calling it TRACS, and it's very in the early stages, but it's a pilot initiative where we're trying to see, let's answer the first question, can we use clinical data for chronic disease surveillance? And we've seen some models that show that we can do that, but can we do that on a statewide level? So we're doing some pilots, and the hope is that we can expand that to other use cases where healthcare systems can begin to answer population-based questions and kind of drive some of the value-based reforms if they can have the full picture of the care that patients receive across the system and where the gaps may exist beyond their own walls. And then the other point, which I know is not the focus of today's presentation, but we wanted to share since that's part of the things you're considering, is on workforce, right? If you look at Dr. Frogner's presentation from UW, really emphasizing that one of the challenges we have is in gaps in information systems for workforce. As an agency, we think the state needs to prioritize really building a robust health workforce information system that can then inform the work of the Health Workforce Council and other partners for whom we all need to come together to make this a priority. So we think this is an area that is ripe for investment as well, is really on the workforce information system, so that we can understand and define the challenges and know when we are making progress and be able to forecast where we're going to run into problems in the future. Next slide. And then again, just emphasizing some of the points already shared part in our presentation is really leveraging the existing infrastructure that we have. We really, the focus, a lot of this is federal funded, the work we do around primary care and Office of Rural Health, but we're really looking at taking a broader lens to how we approach this work and really engaging with partners and sister agencies and in the private sector to see how we can be a catalyst for really a health primary care planning and really understanding where the opportunities for investing in new resources at the community level to address the critical gaps we're seeing. We see that things are not in a good shape. The report that came out yesterday kind of really very timely, again, pointing out to ongoing challenges with primary care. So we would like to continue to see investment in that area. And the other thing we're also investing in internally at the Department of Health is really the idea of translating data to intelligence. So we're investing in health services research capability to be able to really do dedicated work to drive some of the conversations as to what the priorities should be if we're trying to improve health for the population, as well as close health disparities. And last slide, next slide. So lastly, we wanted to again encourage us to think about ways of increasing primary care funding and ways to invest some of those dollars. It's kind of funding innovation in different ways, right? Looking at ways that we can take ideas, pick the problems, and figure out pilot solutions that work, and then seeing opportunities for scaling some of the strategies that work. We've seen some success with that in microfunding, and we'd like to continue to see pilots that really take. We know we have issues, big challenges in the state with access to prenatal care, with primary care generally in the state, and more specifically defined problems around particular disease areas. Can we really identify meaningful and scalable pilots that we can fund, and then kind of have a systematic way of saying we've shown that this is working in communities, then how can we make this a statewide program or system? So just a big picture of things that we wanted to share with you today, but at the core of it is really how can we align the efforts in the public health system with the efforts in the healthcare system to really elevate the importance of primary care, and how can we all have prevention and whole person care as our North Star. Thank you, and we're more than happy to take any questions, as well as connect to other of our colleagues who might be able to address any specific questions you have that we may not be able to address today.
Thanks so much. That was a lot of information and cool stuff you guys are doing. Do people have questions? Sean.
Yeah, I just want to say thanks to Charles, Kyle, and Pat for the presentation, and no questions other than to say that your work is really important, and I think doesn't always get recognized, so much appreciated. It's really important. Thank you. Madeline.
Yeah, thank you. I saw that report the other day too, and our body mass index for preventive things is one of the top across the whole country. My question is, and I've been out of the billing arena for a little over a year, but obesity and the diagnosis of body mass index, if those were the only diagnoses used on a visit, they weren't being reimbursed. So I don't know whether that has changed, or if it's going to change, it would need to change. Do you know anything about that? Because Medicaid was not reimbursing it, nor was Medicare, nor were private insurances at the time. So
I haven't heard of that, but we can look into it for Medicaid.
Okay, thank you.
Yeah, it's my information that I have now is that, yes, it's not being reimbursed to discuss. It's a pretty big issue, and success is limited based on the amount of time and resources that each of the primary care providers or providers have to really address the situation. As you know, it's multifactorial as far as that goes. And so success is really dependent on how comprehensive somebody's treatment plan is set up to be.
Anyone else? Okay, well, thank you very much, DOH colleagues. We appreciate everything you're doing and how we are partnering. It was great to hear about your efforts on primary care engagement in public health. So next, we're going to hear from Gretchen Morley at the Center for Evidence-Based Policy on multi-payer collaborative alignment. So Gretchen, take it away.
Good afternoon, everybody. Don't know if I've spoke yet in these meetings. My name is Gretchen Morley. I work for the Center for Evidence-Based Policy that's located in Portland. I'm here to talk to you about multi-payer collaborative work. It's a policy I think you hit on a little bit in the fall, and we're going to give you a little bit of background of what's gone on nationally in this on this topic, and talk a little bit about what's been going on within your state in the last few years. And some of you have been involved in that, and I recognize your names. Then I will also then turn it over to Judy to add some additional comments, many specific to the new Medicare initiative that is out, Making Care Primary, that I'm sure some of you have heard about as well. So hopefully we can help connect some dots and show how this is a valuable part of thinking about how you get the whole health system moving in the right direction to support primary care. So anyway, this is a slide you've seen before. My box seems to keep wanting to move. We keep trying to nail it down and it moves again. So hopefully that's not too distracting, but obviously this is a conversation that's really kind of core to implementation of policies that increase and sustain primary care. And hopefully you'll see that as we go through. If we can go to the next slide. So just to start with a little bit of history or sort of context nationally, there have been quite a few multi-payer primary care focused efforts over the last 1 to 2 decades. And so what you have here on this slide is really sort of 4 of the really big ones at a very high level in terms of comprehensive primary care initiatives, CPC, you may have heard. Third on that list is CPC Plus, which built off of CPC. There's also the multi-payer advanced primary care practice initiative that ran from 2011 to 2016. And then most recently, the Primary Care First, which is currently running as well. All of these initiatives vary one way or another in terms of how they focus, and they really have built on each other in terms of lessons learned. They all include Medicare. They mostly all include Medicaid in some way, and then an array of payers at the table as well. These are all, while a lot of states and a lot of regions have participated in these, Washington has not yet been a participant in one of these formal collaboratives. I know when we were prepping for this meeting, we had some folks, I know Jonathan, some of the others are on the table. I just want to pause for a second to see if anybody wants to elaborate on any particular aspect of these that might be, more sort of relevant to this group. We could probably talk forever about each one of these if we really dug in, but I just wanted to give a moment for anybody who is intimately aware of these and wants to raise any comments. Okay, just wanted to pause there because it's like this is a lot really packaged onto one slide, and we could go in a number of directions. I'll wait to see what kind of questions we get then. Let's go ahead and go to the next slide. So why would we want to do multi-payer collaboration? This is just, there's a lot of reasons why you might want to do it. This slide tries to, package them up into a neat number of bullets. One is to really drive momentum in a common direction. So the idea that, we have a very diffuse healthcare system, anything that helps to really sort of guide best practices and having various interests working together towards shared goals is only going to increase positive outcomes. Reduce avoidable utilization and costs. This is where ideally you get that alignment, which is we all know is very difficult to do, but on payment approaches, quality metrics, how is data collected, it's synthesized, used, reported in a way that really sort of promotes advanced practice performance. Ideally, it would reduce burden on many of you, or probably most of you on this call, by using alignment, using common definitions, aligned requirements, aligned expectations. You're hopefully reducing the burden of, say, providers needing to satisfy a whole myriad of expectations as they're also trying to provide quality primary care. And then the last one is kind of the math, right? In terms of, enacting a change for more than one payer, it allows for, the provider's patient population to be more accurately covered with this sort of overall direction and, really sort of getting the biggest bang for the buck. So those are just some of the rationale. There are probably 12 others that you all could come up with in terms of why you'd want to do this. Let's go to the next slide. So I'm going to run through just a few brief examples of what other states have done in terms of multi-payer work. And then if anybody has questions that I or my colleagues can't answer, we will be happy to get more information for you. So I'm gonna hit on Colorado, and I'm going to hit on Arkansas and New York. So New York had a multi-payer collaborative for quite a few years. They were participating in both CPC and CPC Plus. They were looking at or trying to prioritize adoption of value-based payment systems, aligning core quality measures for both adults and pediatrics. Using those aligned measures, the payers would be using those aligned measures as existing contracts are renewed, and really working on a centralized claim aggregation and reporting process. Just noting there in terms of some evaluations, Colorado is one of the 4 regions to earn shared savings by bending the cost curve, and then also their average performance scores exceeded those of a number of the other participating regions. And so you'll see the sources down below of where we've gotten this information from, and there is a lot more that you could read on Colorado if you're interested. So that's one example. We can go to the next slide. Arkansas. So Arkansas has a statewide multi-payer initiative that's been running for over a decade now. Very focused on patient-centered primary care home and spreading that across payers and across populations. Value-based payment, metric alignment, and centralized data exchange and reporting. So obviously you can see sort of a common theme developing here across these initiatives. They have a number of accomplishments. They actually have some more recent evaluations. They've been doing a really good job with data in terms of evaluating their progress over time. They have the majority of their primary care providers in patient-centered medical home at this point. They have documented real advances among the primary care providers, achieving sustained practice transformation activities. And there's some examples there like 24/7 access and next day appointments. And then they have a really actively used data exchange. So their share system, the State Health Alliance for Records Exchange, is very accurately or actively used by their providers and payers. So that was that example. And then moving on to the last one, there's the New York Capital District, so the Hudson Valley region within New York. Have been participating in CPC, had commercial, Medicare Advantage, Medicaid fee-for-service, and managed care as well as federal employees in the mix in their in their work, they experienced declines in Medicare hospital admissions, as well as improvement in quality care measures. And they did not actually see a decrease in cost of care, but did not see an increase either after accounting for additional care management fees that were in their design. So anyway, that is really a nutshell of just a few of what has been going on, few ideas or few examples of what's been going on nationally. And so there's quite a bit of momentum nationwide. It's would be really exciting for Washington to continue the work they're doing right now. If we can go to the next slide. Thank you. The call for doing multi-payer work is really just growing. And the report that I'm sure many of you are familiar with is Implementing High Quality Primary Care that was put out a couple of years ago by the National Academies of Science, Engineering, and Medicine. They not only, you can see by the second bullet, they not only recommend what you are all doing essentially here around the table, looking at primary care spending as a portion of total spending. They also really supported the use of multi-payer collaborations to facilitate the move towards VBP and increasing primary care spend. So we go to the next slide. So this is also from that same work. It's actually from a presentation that Chris Kohler, who I think you've all heard of from the Milbank Fund, that presented the presentation he did in Rhode Island, but really pulled out, all of this work is culminating into some best practices. And you can see here listed, this is from his presentation, some recommendations around multi-payer work and, really sort of getting that significant market share, really having the leaders at the table. And this is where I, highlighted the state role, because this is where really you guys all come in as sort of essentially advisors or, making a recommendation to the state and the legislature about what aspects need to really be kind of combined in order to increase primary care spend and support. States really need, the successful efforts, and I'm sorry, my cat is it's just so excited about multi-payer collaboration. That states really need to be there to facilitate this process. They're in a unique position, and then you combine that with bringing Medicare to the table and their leadership and their funding. It's quite powerful. Then there's some other recommendations here of like neutral convener, provider forum for provider learning, which I can mention something on that, and really, have patience. And I think that's a lesson learned for the new Making Care Primary demonstration that's 10.5 years that you'll hear a little bit more about from Judy. But, really that taking into account that, these things don't happen overnight, and you're trying to really sort of pull a lot of people together and have common conversations, and it's a lift. So that's just some background on multi-payer collaborations. Let me pivot to what's going on in your state. And like I said, some of you I know are at these tables, and I apologize if all of this is a rerun for you, but so you have a multi-payer collaborative in the state. It is a group of 9 payers, if I'm getting that right, plus the HCA, who meet regularly. They prioritize looking at primary care. And they have been working for several years now in order to really identify common practices, common sort of directions, and think about where a multi-payer role can be in moving Washington's primary care system forward. And so they signed an MOU showing sort of directional interest in doing this back in 2020. And when these slides, the links will be there to the HCA's website. And then really worked with HCA and others, and some of you were involved probably, whether it's from we had a purchaser group as well as provider summits. Some of you might remember, going back through some of these meetings, but really sort of pull in as much input as possible in developing what is Washington's multi-payer model at this point, and that's also up on HCA's website. So like everything evolves, and nothing is going to sort of stay stagnant. The introduction of CMS's Making Care Primary model is really sort of highlighting sort of need to do some further development in order to continue to ensure that things are going in the same direction. So right now, the collaborative is very active right now. It is convening a provider learning cohort to identify opportunities that payers can align to support practices. So this is a very time-limited set of discussions to really connect payers and providers and try to get to concrete actions that if you had payer alignment, it would help providers move forward on primary care transformation. Then they're also seeking to align Washington's model with the CMS Making Care Primary model, really to bring critical mass for practice transformation. So this is the idea of saying, you know, we're bringing everybody to the table, all payers, all lines of business, and let's see how many steps we can all take in the same direction. And then they are working toward an updated MOU that would indicate kind of next steps, you know, that would be updated from the 2020 MOU. So there's a lot going on. Let me just see, what is the next slide? Oh, this is an overview of the model that if you had seen these documents up on the HCA website, this has evolved over time, and I believe it will continue to evolve, but it lays out the various roles in the model that really, you know, is it's really comprehensive in the sense of expectations and outcomes and everybody really having a key role. And let me just move on one more slide. And I think I'm going to hit on this lightly because this is a good segue to what Judy will talk about next in some of her slides. Making Care Primary, brand new, hot off the press. Initiative from Medicare focusing on primary care. Washington was selected as one of the states. So this is sort of that exciting time for Washington to be involved in one of these big demonstrations. You can see here we had quite a few applicants, and I'll let Judy talk more about that, but there was quite a bit of interest from Washington providers. And those conversations and how we sort of meld it with everything that you all and everybody's been working on, not only this committee, but then also the multi-payer work, how it all can continue to meld together and leverage each other. So I'm going to pause. And I think actually the next slide is sort of something I think we'll be circling back on maybe in subsequent meetings, but the original sort of recommendation was for this committee to essentially issue a statement of support around supporting the multi-payer collaboratives work, aligning primary care transformation efforts with the Making Care Primary program, and really supporting legislative interest and advancement in terms of where there are opportunities to really increase primary care alignment, particularly for the state-funded programs. So that is what I have. Shall we stop for questions, Judy, or would you, maybe we'll pause for questions before we move on to it?
I think let's pause for questions and see if people want to talk about this at all. We've done a lot of talking at you.
Is there anybody who's involved in this work that's interested in giving your perspective?
I see Cheryl has her hand raised.
Cheryl,
Yeah, I'm happy to speak, and you probably won't be surprised by any of my comments. So I'm a pediatrician. So that one, I completely support a multi-payer approach. It's the only way that we're ever going to make progress short of having a single payer. So this is absolutely essential for those of us who are doing patient care for this to make sense at all. So I completely support that. And then I will just say one more time, I would like to advocate for kids to be included in payment transformation in the state. So that's it, but I otherwise completely supportive of all of this.
Yes, and kids are on the list. Making Care Primary is, as Gretchen said, a multi-payer initiative. So the Medicare part has launched, but the rest of it is coming soon. So at least we hope it's coming soon. Any other comments or questions? Okay, then we'll go to my slides. I'm just going to talk a little bit more about some of the local context. So thank you, Gretchen. We're just going to sort of dovetail kind of back and forth from what Gretchen talked about. So this is a slide from CMS about the benefits of that payer partnership for Making Care Primary. And similar to previous models that the Center for Medicare and Medicaid Innovation have had, I think for us, being involved in Making Care Primary builds on the existing efforts that we have started with the primary care transformation, and it brings additional Medicare resources. I'm hoping that will accelerate change and help us get to a tipping point where we have a lot of alignment and can really improve patient outcomes and decrease provider burden. It provides a nice framework for other payers and commercial and Medicaid to sort of follow, along with some lessons learned. It's also quite handy that it very well aligns with what we had arranged already, sort of listening to some of those other models and learning from their evaluation. And one of the goals of CMS is to improve data to practices and aggregating across payers in sort of the long term. So that I think is also worthwhile. Next. Gretchen talked about this. I'm just going to super briefly say multi-payer alignment is so important for clinicians because it simplifies their life, it reduces administrative burden, and it makes it easier to get to VBP goals. And for payers, it's really helpful because you get greater purchasing power. You can make a super cool model, but if a practice only has a small bit of your population, it doesn't make sense for them. And so it really amplifies the impact of value-based purchasing and gets to system transformation. Next. So as Gretchen said, we've had a lot of work here in Washington, as I think all of you know about, building a new multi-payer primary care model that now is sort of lining up with Making Care Primary. So the goals that we had at the outset were to align payment incentives and metrics across payers and providers, to promote and incentivize integrated whole person care, all the mom and apple pie stuff. Next slide. To improve provider capacity and access, to increase primary care expenditures while decreasing total health spending. I think Gretchen shared some nice data about some of the changes that happened in other markets when they did multi-payer work, and to work with public and private employers to spread and scale this model throughout Washington. Next. So Gretchen mentioned this some, but this is just to show you the timeline that the payers started talking in 2019 and signed a memorandum of understanding in 2020 to work on primary care together. Of course, the pandemic hit then, and so things slowed down a little. We had virtual meetings of the payers and of a clinical summit group. And in 2022, we started having a purchaser group, which I think has been really helpful to sort of push all of these things in the same direction. And so now we are part of Making Care Primary, and we will hopefully launch this soon. Next slide. And this just shows that like all of these aligned efforts from all of these groups, I think will get us to a better place in primary care. Next. So the last thing I wanted to show you, and this is hot off the press, but we ran, or I guess ran again, numbers using the old primary care spend methodology using the Washington State APCD. So we wanted to get another data point, especially since we're going to have a little bit of a lag until we have the new methodology and a new data point. And so from the old methodology and from the Washington APCD, primary care spending was 4% of total healthcare spending in 2022. And you can see which parts are the broad definition and which are the narrow. And I apologize because there's two figures sort of put on top of each other. Next slide. So you can see there's some nice trends here. So starting at the bottom, the first year that the Office of Financial Management measured this, we were at 5.6% primary care spending. This is looking at both the broad and narrow together. It went down during COVID in 2020 to 5.2. Last year was 5.3, and this year is up just a smidge to 5.4. But that is still plenty to go to get to our 12% goal, which is this committee's charge. Next slide. This shows some of the changes, whether you're looking at the narrow definition, which is the light colored blue, or the broad definition. I think it will be really helpful for us to just have the one definition and sort of simplify this for talking about. But you can see there was an initial increase in 2019, and then it went down with the pandemic. And I don't know, I'm an optimist, glass half full, so I think it's going up. It's just going up quite slowly. Next slide. This shows the range of primary care expenditures by age. So you won't be surprised that kids have the highest part of primary care expenditure because otherwise they are mostly pretty healthy, and it's well care visits and sort of acute smaller illnesses and injuries that folks go to their pediatrician or family practice. For 65 and over, it's sort of the smallest, and then that middle group, it has a broader range. Next slide. And then this is just that how it's changed over time in a graph. So the sort of bright blue line in the middle is the statewide spend. And then the, I don't know, yellowish brownish line at the bottom is primary care spend for those 65 and older. The gray line is for the 18 to 64-year-olds. And then the top line is for kiddos. And, you know, one thing that I think is kind of a bummer is that while it looks like most of the gains have really been made in the 65 and older population, but I think kids and 18 to 64 are really pretty flat. Next slide. So this is the percent of primary care expenditures by payer type. So the first bar is statewide, and again, that range of narrow and broad. And then there's PEB, the public employees. There's Medicaid managed care, there's Medicare Advantage, and there's commercial. And so you can see there's sort of a range in each of these. And I think the next slide maybe shows that trend over time. Oh, yes, it does. And so you can see that there hasn't been a big difference, except that the Medicaid managed care line, which is the gray, really does seem to be going down. It hasn't flattened out. So I think there's probably more work to do in Medicaid. Next, oh, and I guess that's the last slide I have. So you can go back to that last slide. And do people have any questions or more comments about this?
Judy, this is Michelle. Can you remind me if this data includes non-claims-based payments, or is it only claims?
It is only claims. In this is the original definition. And so it's only claims. And actually, that's a good thing to note because we have been collecting, as we've shared with this committee before, non-claims-based spend, and particularly in Medicaid, I think our MCOs have done a great job of adding some of that non-claims-based spend to primary care. Most of the value-based care that is being done by the MCOs is being done in primary care, and there is more value-based care done in the MCOs than there are on PEB and SEB. So that may account for this decline. I am super excited. I think it'll probably be the end of this calendar year, but to get our new definition that includes claims and non-claims based spend, and has just one definition that we can sort of track over time. So I was hoping to get this earlier, particularly earlier in the lead session, but that didn't happen. But I think it is good data to sort of give us a sort of a snapshot of where we are. And I think the answer is probably not a lot different than where we were last year. DC?
Yeah, hi Judy, thanks. Not sure I followed your last comment about the PEB and stuff. So, but my question is, do you have a theory about the drop in Medicaid and PEB for primary care? Because these are kind of the wrong direction, right? And yet those programs, I mean, I'm very familiar with the PEB. It certainly, I think, tries to create incentives for primary care alignment. And I think that's probably true for Medicaid managed care as well.
Yeah. So every year we do a survey of value-based care to sort of, because we have that in all of our contracts. As you know, DC, PEB, SEB, and Medicaid. And so we get sort of an idea of sort of how that's progressing. And we've done that, I think our first year of measuring was 2016, so quite a while now. And one of the things that we noticed this year, we sort of dove into the data a little more, and it appears that Medicaid MCOs have more value-based care arrangements than PEB and SEB. And it appears that most value-based care arrangements are really in primary care. There's not a lot of other ones. So that is sort of interesting. I agree with you that these trends are concerning, and especially 2 years out of the pandemic, I would be hoping that this would be getting better. Maybe that's a lead in that our next meeting, we're going to start to vote on different issue papers. I think we might have 3 at our next meeting of the topics that we've covered so far. So workforce, patient engagement, and this multi-payer alignment. And the goal would be for this committee to make those recommendations and get them to our larger cost board so that they can make those recommendations and give them to our legislative report that will be delivered to the legislature later this year so they can consider that for next session.
I'm sorry, are you saying then that the value-based care influence in managed Medicaid may unintentionally be driving down primary care spend disproportionately or selectively?
Oh, no, I think that that Medicaid managed care has more non-claims based arrangements with primary care than the commercial side does. And so it may be that some of this decrease keeps the spending flat, but more of the spending is in non-claims based arrangements. I don't know that because we're sort of pulling from different data sets for this. But that's one of my theories. I don't know. Michelle, you do both sides of our house. Do you have theories about that? Or maybe you stepped away for a minute.
Hey, Judy, though it's Cheryl. I mean, I would say personally for our network, that is definitely true that we have several arrangements with MCOs and, PMPM care management and some behavioral health, et cetera, that would not have been captured in claims at all.
Yeah, the other piece that I think is interesting as we have looked at our spending recently overall in Medicaid is that we have really put a lot of investment in behavioral health. And the legislature has directed us to put a lot of investment in behavioral health. And so if you followed along with the initial results of the cost of care that was presented to the overall cost board, you can see that Medicare expenditures have been going up in general, and that's because there's been a lot of money and effort put into behavioral health. And so that may also affect this trend that overall when behavioral health that isn't in this pie part so much may be squeezing down primary care, even though some of the behavioral health is probably being provided in primary care offices. But that is not what this original definition measured as much. It has a narrower segment of behavioral health. So if there's nothing else to chat about today, I really do, I'll re-emphasize at our next meeting, we're going to vote on the workforce issue paper, and we'll have at least one, but maybe two more issue papers for you to consider and vote on next time. The person engagement in primary care and this multi-payer alignment piece. So look out for those documents that will be sent out. Our next meeting is March 28th, and the recording and summary of this meeting will be posted shortly on our website. Thank you all for joining, and I look forward to chatting with you again soon. Take care.
Thank you. Thank you.